Knowledge is power. Yes, knowledge can be quite powerful, but it can also be extremely scary, which is why it's a perfectly normal response for us to be filled with anxiety, scanxiety we call it, when the time comes around for us to get our regular scans that monitor the effectiveness of our treatment and give us insight into whether our disease is spreading or not. These are naturally stress-filled times, but it's important for us to distinguish between the knowledge that the scan affords and the underlying disease itself. Putting off a scan or being reluctant to learn the results of a scan, it's not going to change the underlying disease. It's a bit like avoiding a photograph because you don't want to capture a particular scene. The scene is going to be what it is, photograph or no photograph. The disease is a terrible thing, but knowledge can only be good. Knowledge offers us the opportunity to make strategic decisions about how we're going to fight the disease. And most treatment decisions are very time sensitive. The sooner that we have complete information and understand that information thoroughly, the better equipped we are to take positive steps forward. Recently, I attended the International Lung Cancer Survivors Conference held in Washington, D.C. and sponsored by Longevity. In one session, Dr. Jose Pacheco, one of a handful of leading lung cancer doctors in the world that came to spend a couple of days with us to share knowledge and expertise, did a session on the basic science of lung cancer. Many people who were unable to attend that session asked if there was some way that I might record some of the knowledge and expertise that Dr. Pacheco planned to share. When I returned home and started editing some of the footage that I shot in DC, it struck me how important Dr. Pacheco's session was. Sure, he labeled it the basic science of lung cancer, and it might be relatively basic to him, but I was struck by how comprehensive his session was. The knowledge that Dr. Pacheco shared can only be good. Sure, in some cases this may lead us to outcomes that we don't like, but the knowledge better equips us to do the best we can. To that end, I've divided Dr. Pacheco's session up into 3 segments, 101, 201, and 301, and I'm sharing them here on the Living Wide channel. Thank you, Dr. Pacheco, for sharing your expertise, which is so important for advocacy on behalf of ourselves and others like us. Knowledge is power. And remember that knowledge is most powerful when it's shared. So please share Living Wide with anyone who you think might benefit.
Which is about 80% of cases, small cell lung cancer, which is about 15%, and then there are some other less common histologies, which just describe the way it looks under a microscope. Within non-small cell lung cancer, there are also a variety of different histologies themselves, most common being adenocarcinoma. There's also squamous cell, large cell, and bronchoalveolar, which is another type of histology. And there's a few very uncommon kind of histologies that are not listed up there. Now, within lung cancer, there are a lot of different molecular abnormalities someone can have within the tumor. This is not an all-inclusive list, but it's fairly comprehensive. The more common ones are things like KRAS, which, depending on the study you look at, will be about 25 to 30% of cases of non-small cell lung cancer. EGFR activating mutations will be present about 15% of cases of non-small cell lung cancer. ALK fusions about 4 to 7% of cases. ROS1 fusions about 1 to 2%. And BRAF V600E mutations, about 1%, a little bit above that. And then MET exon 14 skipping mutations are found in about 4%. Now those are kind of the molecular, and then intract fusions are found about 1%. Yes?
Do all lung cancer patients have a genetic abnormality?
There's not all.
Can you repeat?
Okay, yeah. So the question was, do all lung cancer patients have a genetic abnormality? And the answer is, as far as the genetic abnormalities we've identified so far, no. So there are still a lot of patients where we do a very comprehensive panel and we don't find anything altered, or we don't find anything altered that we can target with a medication.
Have you slides as part of the package, or?
I think they'll be made available. The slides?
They're on the app. If you have the app, they're on the app, and if you don't have the app, just email me and we'll send it to you.
Okay.
So the ones that I highlighted, minus KRAS, are ones that have approved targeted therapies. And the EGFR, ALK fusions, ROS1 fusions, those are the more kind of ones we've heard more about. They're more common in adenocarcinoma histology, more common in non-smokers, but they can still be found in some cases of patients who are former smokers. So within our body, we have lots of cells, millions of cells, and within each cell, we have material that goes from DNA to RNA and then to a protein. And the protein is kind of what does things. It's the ultimate product of that, and it is responsible for functional consequences. So DNA, within it, it has these things called introns. As they're chopped out, we go to RNA, and then that's made into a protein, which has some sort of function. Now, people talk about fusions versus mutations, and so some people in this room may have fusions in their tumor, like ROS1 fusions or ALK fusions, and other people may have mutations within the tumor. And those things are different. So in A up there, which is on the top, I tried to illustrate an example of a mutation, which is something totally different than a gene fusion. So a mutation you have on the left there, gene 1 and gene 2, they're the same shape. They're kind of these red rectangles. Gene 2 on the right, on the top there, figure A, has undergone a mutation or something that's altered its structure. So now gene 2 is no longer a red rectangle, it's undergone a structural change or a mutation within it. And so those mutations within genes are things like EGFR activating mutations, which can lead to an abnormality in the protein as it goes from DNA to RNA to protein. Now, gene fusion is different. Gene fusion is on the bottom. On the top of figure B on the bottom, you have two genes that are red rectangles, gene 1 and gene 2. You have two additional genes that are kind of yellow rectangles, gene 3 and gene 4. What happens in a gene fusion, such as in ALK fusions, ROS1 fusions, and I would say we don't know why this happens, is that there's some sort of event that occurs whereby two genes that are not normally next to each other are placed next to each other. As you see kind of in the bottom there, you see gene 2 and gene 3, which weren't originally next to each other, are placed next to each other. Now when that happens, it's usually the gene, like the ALK gene or the ROS1 gene, is going to be placed next to something that is normally turned on all the time and is necessary for normal body function, such as a gene that's essential for making nails or skin. And so what happens is it gets placed next to something that's essential for that's going to be turned on all the time or essential for normal function. And when that happens, the ALK gene or the ROS1 gene kind of gets constantly turned on, or it can be if it's placed next to the right gene, and that can predispose to those types of cancers. Gene amplifications, someone brought that up the other day in one of the sessions. So those are a little bit different. Gene amplifications on the top there's gene 1 and gene 2, and I didn't have enough space to spell out the word gene to kind of illustrate the point. But a gene amplification, basically, you have, instead of having one gene that's altered, like the structure of it, you have basically a change that happens, and I would say we don't always know why this happens, and you get a bunch of extra copies of a certain gene, like there's a bunch of extra copies of gene 1 and only one copy of gene 2, and that would be kind of an example of a gene amplification. And what that causes is it causes a lot of excess normal protein on the bottom, on the surface of a cell. That could be a cancer cell, and that can lead to abnormal communications in that cell, telling it to grow abnormally. So there are different ways we can detect these abnormalities. Mutations can be detected by DNA-based next-generation sequencing. That's most of the ways we detect them. Those are things like Foundation Medicine. There are a lot of other companies that have DNA-based next-generation sequencing tests to detect mutations. Fusions are best tested by RNA-based next-generation sequencing, or FISH. Now, you can, ALK fusions, like ALK fusions, ROS1 fusions, they can be detected by DNA-based tests like Foundation Medicine, but that can miss a fair amount of mutations because if you, a fair amount of fusions, so it misses, some estimate up to 30% of fusions, and part of the reason is when you look at the DNA there, it has those introns within it, and so sometimes those introns, if you have a fusion event that involves an intron within it, that'll mess up kind of how that those DNA-based next-generation sequencing tests detect fusions. And so the RNA-based tests are much more accurate and better at detecting fusions. So there are some patients that will kind of undergo a comprehensive panel, and they're told that they don't have any targetable abnormalities, but they may have only undergone a DNA-based next-generation sequencing panel. The optimal way to do it is to do it both a DNA and an RNA-based sequencing panel. Now, RNA-based sequencing panels, most of them are going to be found kind of at academic institutions. Most of the commercial things available are going to be DNA-based. FISH, though, can be done. You don't have to go to a special center to get that. Amplifications are best detected by FISH, and then protein overexpression is the best detected by something called immunohistochemistry. Now, we use protein detection to kind of screen sometimes for ALK fusions, but we don't use it as a confirmatory test. So we use it, and then if we find ALK overexpression by immunohistochemistry, then we sometimes do a more expensive test like FISH. Protein overexpression is how we detect things on the tumor like PD-L1, which some people may have heard of. Yes?
I read in the literature that usually the sample is not big enough to test for every mutation. How do you decide what to test for?
Say that again.
Sure. I read in the literature that the sample is usually not big enough to test for every mutation. I wonder, how do you decide what to test for?
So it depends on the type of sample. So there's samples where they do things called fine needle aspiration, where they just get a few cells. Those are most common when people get a sample by bronchoscopy. There are people that get what we call a core needle biopsy. And usually, for a lot of times, if those are done well, you can get tissue to do most everything, not always. Now, that is when you don't do individual tests kind of in sequence. So some people still will do, I would say most of the academic centers, we don't do this, but at some other centers, they'll get a sample and they'll send it for EGFR activating mutation. and then that's negative, then they'll test it for something else, and then they'll test it for something else after that. When you do it that way, sometimes you do use up a lot of tissue. Also, I think that will get less common, and we'll be able to detect more things now that some of the next generation tests, like DNA-based tests, are now FDA approved. There's 2 of them FDA approved. The Foundation Medicine test, and there's one, an MSK impact test. Those are now FDA approved, and since they're FDA approved, I think we'll get less instances of where we don't have enough tissue, but there still are going to be, unfortunately, instances where there are. Now, oftentimes we don't find that till we kind of send in the sample. So in those cases, if I send in a sample and I'm told there's not sufficient tissue, you can only do, sometimes, usually our pathologist is good, so she'll say, you can only do these tests. And so then we say, well, it's based on our suspicion of kind of what is kind of the patient's profile. And I know we talk to some extent not about profiling, but if we have a patient who is a never smoker, who is newly diagnosed, we're going to be less interested in using the tissue for testing for protein overexpression, maybe for PD-L1, and we'll be more focused on doing the FISH and the next generation sequencing looking for mutations. If we have a patient come in who's newly diagnosed, who is a former heavy smoker, we may be more likely to do the PD-L1 testing and then a targeted kind of just DNA test for KRAS. Now there are KRAS mutations that are found in non-smokers as well, but it is more common in smokers. Yes?
I don't know if this is appropriate, but I knew.
I don't think there's no rules, so you can ask whatever.
Thank you. I'm newly diagnosed, and the diagnosis was malignant neoplasm. Neoplasm. I have a mental block. And I don't know where this fits on anything.
You mean malignant neoplasm?
Yeah.
Okay.
I don't know what that means, and I haven't had a chance to pursue it.
Okay. So you haven't started treatment yet?
I had surgery.
Okay. Well, malignant neoplasm is, it means, like, if we go back, did they tell you had lung cancer?
Yes.
I imagine, over here.
Yes.
Because neoplasm just means kind of tumor.
Okay.
So if they just told you had a malignant neoplasm, it means that they weren't sure. If they just said malignant neoplasm and not, sometimes people say non-small cell lung cancer, not otherwise specified, they'll use that term, which means they can't tell if it's adenocarcinoma, squamous cell, large cell, or another type of non-small cell lung cancer. I suspect that's the term they probably used in you. Sometimes they'll use malignant neoplasm. Sometimes it could mean, and they say it's lung cancer, it might just mean they couldn't tell what type of lung cancer it was under the microscope. That would be another. So if they said non-small cell lung cancer not otherwise specified, it means they could tell if it was non-small cell or small cell. If they say malignant neoplasm, usually it would mean they just can't tell what type of lung cancer it is under the microscope.
Okay, thank you, because I could never figure out where it might fit. Thank you.
You're welcome. And so a lot of patients will ask about, kind of when they're newly diagnosed and they're told they have a genetic abnormality in the tumor, they'll ask a lot if it's something that they can pass on to family or if it's something they inherited. So there are 2 different types of common genetic changes or mutations. There are somatic mutations and there are germline mutations. Somatic mutations are most of the mutations will have them that are associated with lung cancer. Meaning you don't have them when you're born, you develop them over time, and they're just found in the tumor. So if you have a lung cancer that is and a few spots in the bone and in your lung and in the lymph nodes, those mutations would be found in those areas, and they wouldn't be found in normal liver, and they wouldn't be found in the skin. And they wouldn't be something that you would pass on to children. Germline mutations, which are very rare in lung cancer, but can occur, those would be things that you would be born with, that they could be passed on to family members, but they wouldn't just be found in the tumor, they would be found in normal areas of the body as well. So not just in the areas that had cancer, but also like in normal skin or normal liver. There are a few reports of inherited cases of EGFR with T790M mutation, but those are very rare. There are rare cases of lung cancer that are associated with inherited P53 mutation, but those are very uncommon. And a lot of people with lung cancer have P53 mutation. The difference is in the inherited type, usually family members get a lot of other cancers very young, like leukemias, sarcomas, in their 20s, in their 30s, much younger than that sometimes, and all sorts of other cancers. So it's it presents much differently than people getting cancer much later on or getting only one type of cancer.
So what you're saying is that someone that has EGFR mutation is not likely that that's passed on to children?
Yes.
It's somatic.
Yes, almost always somatic. But that's a very common question, I would say, when you first present those results to a patient. Now, cancer, the most common way it spreads is by getting into the lymph nodes. It can also spread by blood, but lymph nodes is by far the most common way it spreads to other areas of the body. So here on the left, there's a pair of lungs. Around that tube that kind of goes down and branches into two sides, that's the trachea, or the airway that goes from the mouth down to the lung. Those little circles around the airways are lymph nodes. So those lymph nodes, first, if you have cancer in the lung, first it usually spreads to the lymph nodes, these circles here around the airways. And if you look on the right, you can see those purple kind of circles, those are lymph nodes. And they're all you have them throughout the body in various different locations. They're all interconnected. It's not a highway system, but you can kind of think of it like a highway system. They're all interconnected. So the most common way it spreads to other areas of the body is it spreads from the lung to these lymph nodes in the center of the chest. And then once it gets there, it can go to other areas because all these lymph nodes are really interconnected. The most common site of spread is actually the lung itself. That's the most common area that lung cancer spreads. So other areas of the lung, the lining of the lung. Other areas it commonly spreads are bone, liver, the adrenal gland, which is on top of the kidney, and then the brain as well. Now, the reason why we sometimes test blood or do this liquid biopsy is because some tumors, as they grow, some areas of them will outgrow their blood supply. Those areas that outgrow their blood supply, some of those cancer cells will die. When they die, they'll release their DNA or genetic material into the blood. So by using one of those DNA-based next-generation sequencing tests, but on the blood, doing a liquid biopsy, we can detect some of the mutations in the blood. We can also detect fusions, like ALK fusion or ROS1 fusion in the blood as well, but those tests are probably better for detecting the mutations.
It's Living Wide's mission to help everyone lead lives filled with meaning and purpose, despite the uncertainty of life-limiting illness. Thanks for stopping by. Hit that like button and subscribe if you haven't already. And share this with friends. Literally, the more engagement we can get here on Living Wide's channel, the more people will be able to help. Thank you for being a part of what we're trying to do. More soon.